Hello and welcome to this webinar on suicide in veteran and military populations. A very warm welcome to all of you who've joined us for the live activity today, and judging by the number of people who've logged on, it's clearly a topic of considerable interest. Welcome to those of you who are watching us later, and a very warm welcome to our panel who I will introduce in just a moment. First, I'd like to acknowledge the traditional custodians of the lands across Australia upon which our panellists and our participants are located. I'd like to pay our respects to their elders, past, present and future. And in the context of this series of webinars, I'd particularly like to acknowledge the many Indigenous men and women who've served in the Australian Defence Force over the years. This is obviously a very difficult and sensitive issue, but I do think it's one that it's really important to talk about openly and honestly. So by the end of this webinar, we hope that you'll have a better understanding of some of the issues around suicide, a bit more knowledge about risk and protective factors and about warning signs perhaps, and also importantly, a bit more confidence in how to help yourselves and how to help other people if they're having thoughts about suicide. My name's Mark Creamer. I'm a clinical psychologist in private practice and a professor in the Department of Psychiatry at the University of Melbourne. And I've had a very long interest in the mental health effects of trauma, but in particular in veteran and military mental health. And as a clinician seeing veterans and civilians, issues of suicide, suicidal thoughts and suicidal behaviour often come up. And so I'm very pleased to be able to facilitate this discussion today and to draw on the knowledge of our panellists. So without further ado, let me introduce them. Now, you have their full biographies, so I will keep it very brief. Tom Glede served in the Royal Australian Navy from 1994 to 2000 on guided missile destroyers. He was involved in a serious fire and subsequently was medically discharged from the Navy with severe PTSD and depression. Tom talks very openly about his struggles with mental health issues, and we're going to be hearing a bit about that today. But with a great deal of hard work and a lot of help, he pulled through, and he now works as a peer advisor in the Sydney VVCS office as part of their community engagement program. So welcome, Tom. Thank you very much for joining us.
Thanks, Mark. It's great to be here.
I heard through the grapevine, Tom, that you've had a bit of a sporting achievement in recent times.
Yes, I have. Last weekend, a group of myself and my friends won the cricket final. It was great. We were made up of 6 old blokes and 6 young blokes, and it's always good to pass our knowledge. And we had victory. I
won't ask which category you fall into, the old blokes or the young blokes. Yeah, anyway, that's great. It's always good to win a grand final, isn't it? And I was wondering whether we should talk about the Australian team, but I'm not too sure about that.
Well, it is developing. It was a shock to the whole nation, but more importantly, I think with the events that are happening now, it's more important for their family and friends and the community to get behind them and make sure they're okay during this process.
Yeah, fair point. I think we do tend to underestimate the amount of pressure that our sportsmen and women are under, don't we? Thank you very much, Tom. Nicole Sadler served for 23 years in the Australian Defence Force in Army psychology, and over that period built up considerable expertise in veteran and military mental health. She provided support on numerous overseas ADF deployments, and from 2012 to 2017, she was the senior psychologist in the Army. She's a colonel currently in the Army Reserve, and she recently joined Phoenix, Australia Centre for Post-Traumatic Mental Health in the role of Director, Military and High-Risk Organisations. Welcome, Nicole. Thanks very much for joining us.
Thanks, Mark. It's great to be here.
Now, we've known each other for a long time, Nicole.
Yes,
we've
we have.
worked together for many years, and it's extremely rare for me to see you in civilian clothes. I'm just wondering, it must have been a big transition for you.
It was a big transition. People always warn you that it'll be a big transition, but probably didn't realise how much it would be, even though I came out of the full-time Army in July of last year. I'm still adjusting to things, but I was extremely fortunate to go straight into a role where I still get to work with military and veteran populations, which has always been my passion and always will be my passion.
Yeah, that's good. And that broader issue, I suppose, of being able to be in employment that is meaningful and worthwhile.
Yeah.
That's so important for our mental health
extremely
and
important.
psychological well-being. Anyway, great to have you with us, Nicole. Now, before we get started, I do need to just do a tiny bit of administration. So if you've got any technical difficulties, there's a number on your screen to call, 1-800-733-416. In terms of today's webinar, we're going to spend the first 30 minutes on some presentations from our panellists and the second half on questions and answers. Now, many of you have already sent in questions, and there's some very insightful, perceptive questions that you've sent in, so thank you very much for those. You can also submit comments or questions as we go along through the website, and they come up on a little screen in front of me here. So please do that, and we will try to get through as many of them as we can. Please bear with us if we don't quite get through them all. There will be a recording made of this webinar, and that will be available in about a week, and we'll send you a link to that. And finally, can I ask you, please, when the webinar finishes, to complete the feedback survey? It's really very important for us. And I don't want to overdo it, but I think it is important to make the point that this is a difficult topic. As I said earlier, it's a very sensitive topic. And I do think it's really important that we discuss it and that we talk openly about it. But of course, if it raises issues for you, please get in contact with someone, a friend, a family member, a mate, a psychologist, your GP. And of course, never forget that VVCS is there 24 hours a day, 7 days a week. And the number is on your screen there, 1-800-011-046. Okay, that being said, I would like to move to the first of our panellists, Tom Glede, to tell us a little bit about his personal experiences and particularly perhaps with reference to suicide in terms of his own experiences and his experiences as a peer advisor. So thank you, Tom. Over to you.
Thanks, Mark. Well, I joined the Royal Australian Navy in 1994 and I served for 6 years. I was an electronic technician and worked on the 5-inch weapon system and absolutely loved it. It gave me a sense of purpose. I loved the camaraderie between myself and my fellow shipmates. I was plenty active. I played lots of sport. It was a great way to see the parts of the world, and it was also a great way to kick off my career. Unfortunately, during my last year in the Royal Australian Navy, I was involved in a 5-inch gun accident, and where we had an explosion inside the gun. From that point, it was probably from that point on where a switch had just gone off inside me, and I started my my journey in mental health. I was medically discharged. And at that time, I felt a little that I'd let down my teammates. I started turning to alcohol to numb the effects, and I unfortunately also chose to use prescribed medication that I was on to help me with my PTSD, and my depression and anxiety was increasing because I was also increasing with my illicit drug use to help me sleep. I wasn't really accepting of my conditions, and I didn't treat them with the respect they deserved, and I went on to abuse drugs and alcohol. I then became a workaholic. So another part of my condition, I threw myself into work as a way of avoiding my conditions, and mixing that in with a sense of loss and the grief. I was newly married. I also had just purchased a house. So all those external stresses also, part of transitioning, really sort of tipped me over the iceberg, I'd say, and it got pretty grim there at stages. And being a big man as I am, I found it hard to reach out. And it wasn't until my wife at the time said, you really need to seek some help. After a separation, which is fair enough, because I wasn't treating my condition with the respect it deserved, I had started wearing out my relationships with my loved ones, and started losing contact with my friends through my behaviour, which they didn't approve of. And there came a pinnacle point with my illness where I felt very alone and very sad and lost and confused, to the point where I thought there was no other way out. I'd had enough, and what happened it happened so quick. I was shocked. If you had asked me 2 years before if I'd ever contemplate suicide, I would have maybe laughed and not respected those words and just said, "You're kidding me." But over a 48-hour period, I remember distinctly, I was sitting on the couch. I just split up from my second relationship. I had stopped working, and I was grieving the loss of a sibling. Now, all those combination and external factors, as well as my mental health, contributed to the point and got me to the point where I was contemplating suicide. I just thought there was no other way out. And so I had, my alcohol. I had the means of wanting to do it. I had a plan, and I was actually starting to go through that plan. And part of that plan was looking at a table of family photos and actually saying to my family, saying my goodbyes. And I got to a certain particular photo, and it made me reach out for help. Although I was feeling very lonely, as I said before, I'd worn out my family and my good friends, and rightly so. And I just had this moment where I thought I had enough sense about me, or there was something that just made me reach out and ring my psychologist, my treating psychologist at the time. That was the best thing I ever did. She was quite concerned. And for that moment, when I rang her at that time of despair, it was giving me, as she was asking me questions, I didn't really realise what she was doing at the time. As I said, I was in the midst of it. And what she was actually doing was creating or helping me create a safety plan for the weekend, because, as I said, it was on a weekend. I couldn't see her. I couldn't drive. I was under the influence of alcohol. My family, my close family, they were at a family function interstate. So the best next option was to create a suicide safety plan. And what that is, it's just an agreement, like a contract between the person and the person that's wanting to commit, wanting or planning to commit suicide. That plan, it saved my life, or in that moment. It's why I'm here today on this panel, being able to share my lived experience. And just a couple of things on that safety plan that my psychologist made me put on there. She made me think of things that were worth living for. So the first thing to me was my children, obviously, and that was a big factor of remaining me in safety, wanting to be there. And she made me realise, like, the actions that I was planning to do or to take my own life wouldn't put my children in a good stead. Also, she made me think, when I was having these, if after I got off the phone from her, we made commitments of 3 times over that weekend where I would text and check in with her, and then she would call me. So, as I said, it put that little seed in my head that I've got a responsibility for the next 4 hours to stay alive so I can call my psychologist. The other important things were if I couldn't get onto the psychologist, we had to have a backup. So I did put on, at that stage, my dear long life friend, my friend Jason. I put his number down as my second contact. My third contact, I actually, as I said, I was that desperate part of my life where I actually wanted to, I was involved in my second separation, but I actually put my ex-partner down as my third contact because I was that desperate. And in the end, I put down the emergency phone numbers and lifeline. What this safety plan did, it gave us the time to then follow up. My psychologist followed up with me on the Monday, and we started to proceed in getting me admitted to professional help into a hospital. Best thing I ever did with that hospital, I was pretty broken when I was there, but 2 hospitalisations and a lot of self-help during that process got me to a stage where I could then start thinking about how I'm going to reconnect with the community. And so after my second hospital visit, I got out and I became, I had to reach out. I was homeless and I reached out to Homes to Heroes, which is a homeless program for the veterans under RSL Life Care. And they put a roof over my head while I was getting better, while I was taking the Band-Aids off and seeking the help that I wanted. During that time, my time there, I experienced equine therapy, which was great. It gave me the sense of responsibility again, and having that connection with others, with a horse, was fantastic. I also, through them, I had a lot of financial difficulties, and I had to call on RSL Defence Care, which helped me with them, and they also gave me my first job when I got well enough, and that was a peer-to-peer coordinator, which I thoroughly enjoyed. Where I am now, on that peer-to-peer journey, I did a course, and on that course, these 3 circles have stuck with me that I learnt, and they are connection, health and meaning. And when they all come together, I feel really balanced. Part of that, part of my connection was going out, being part of a sporting team, which is my cricket team. You can see I've got my friends up there with my family. Reconnecting them gave me the meaning. And going back to work and working in a field with people I understand and have gone through stuff like myself really meant, has really put me in good stead, and I thoroughly enjoy it. And doing recreational activities, It's all been a big learning curve for me, but at the end of it all, I'm just glad that I didn't decide to take my life at that stage. And there is hope on the other side of things. Just reach out and get help.
Absolutely. That's a really important message, isn't it? Thank you so much, Tom. I think that kind of lived experience perspective is so important for us. No matter how much we professionals talk, it's having someone like Tom talking from their experience is so important. And there's a million things that I'd love to pick up on, Tom, but we're very, very short of time. I suppose one of the things that really struck me was the importance of your psychologist being able to help you take a step back and look at alternative views and look at what you'd be missing and what the impact of you taking your life would be. It sounds like that was pretty important, and particularly remembering the children.
It was pivotal because you're basically so on yourself and you can't see, you've got tunnel vision, you can't see that, everything's shit in life, you can't, you just think it's the end. To someone to stand back and be able to point out your good things in life, because there's always good things. That's not always as bad as you at that time think.
I agree entirely. And that, that comment about sort of tunnel vision, about only being able to see one thing is, I think, really common. Anyway, thank you very much, Tom. We will be talking to you again in just a minute. I would like to hand over now to Nicole to give us an idea perhaps about what the literature says and what the kind of agreed best practice is in this area. So over to you, Nicole.
Great. Thank you, Mark. Now, in these few minutes, I'm certainly not going to try to cover everything that we know about suicide, but I want to highlight a few things, in particular to provide some context to our future discussion that we'll have. So we know that this is a worldwide problem. It is the leading cause of death in Australians aged between 15 and 44. And despite enormous investment in terms of money and research, we're still seeing global trends of a rise in suicides. And, of course, suicide is a significant concern in military and veteran populations. Now, research tells us that generally there's a continuum of suicide expression. So if we think about suicidal ideation, which is those people who are thinking or talking about suicide, we see suicide ideation, suicide plans and suicide attempts. Generally, they will precede a completed suicide. Suicide attempts in particular are a big risk factor for future risk of a completed suicide. And obviously one of our things that we try to strive for in terms of suicide prevention is to intervene early on in that continuum, and certainly before we get to the stress and trauma which can be involved in a suicide attempt. What do we know about completed suicides in serving and ex-serving ADF members? Quite recently, the Australian Institute of Health and Welfare, on behalf of Defence and the Department of Veterans Affairs, did a study of completed suicides in serving and ex-serving members to look at what are the characteristics. And so they had a look at all certified suicides between 2001 and 2015 for people who'd served at least one day in the full-time military. And what that told us was that, in fact, there seems to be a protective element of being in the full-time military, with those people having a significantly less risk of suicide than the general community. But what we do see is that that risk increases as people transition into the ex-serving community. And particularly that risk is significantly higher for those who are aged between 18 and 29. And this was only looked at for males because they were the significant proportion of those people who had completed suicides. And we also see higher risk for those who discharge of lower rank, so those who are not commissioned officers at the time of discharge, and for those who are medically discharged. We didn't find any differences between the single services, and we also didn't find any differences between those people who deployed versus those people who had never deployed on operations. So there's some good examples of risk factors for suicide. And in fact, Tom gave us some really good examples of all types of things that were happening in his life which we would see as risk factors for suicide. And generally we'd see those as fitting into two categories. Some of them are static, so they're fixed. For example, your gender is fixed, or historical, things like whether or not you have previously had a suicide attempt, or whether or not you have a trauma history. But others are dynamic, so that means that they can be changeable, and in fact they can change incredibly quickly, and they are things like what your current circumstances are and whether or not there is a significant stressor which is going on in your life at that particular time. So whilst we have this list of risk factors, which is important because we know that they're associated with suicide, it's also challenging for various reasons. First of all, they're actually not very good predictors as to who might be about to attempt suicide or complete suicide. A good example is a mental disorder. Mental disorders are very strongly associated with suicide risk, but most people who have a mental disorder do not attempt or go on to complete suicide. Also, most people will have at least one, if not more than one of these risk factors at any one time. And we also know that there is no typical risk profile. And generally it's accepted that suicide risk comes from a complex interplay of all sorts of factors which are going on for a person. And again, Tom gave some really good examples of all sorts of things which were going on in his life, some which came from historical over time and some which were happening at that time for him. We also then like to think about warning signs. So these are the things that tell us that perhaps there is a more immediate risk that this person might be going to attempt suicide or complete suicide. Some of them will tell us that this person is just generally in distress, is overwhelmed, is having trouble coping with things at the moment. Where other ones will tell us that this person is perhaps at immediate or at higher risk. And these are the ones where we need to be taking immediate action. And they include if someone's threatening to hurt or to kill themselves, if they're seeking or in possession of lethal means, and I mean things like weapons or that they've got a stockpile of medication, or if they're talking or writing about suicide, death or dying. That can be face-to-face. It can also be through social media. If you're seeing any of those things in somebody, you need to be getting them assistance immediately. Calling 000 is a great way of getting that assistance, and stay with that person. Do not leave them alone. If we think about risk factors and warning signs, we also like to think about what are the protective factors. And in considering protective factors, we need to be considering those that may already be in the person's life or those which are missing and perhaps we need to try to bolster or improve in their life. This is a list of all sorts of ones that we can see as being protective and are great things for just people's general health and well-being. But a couple that I'd like to highlight is the importance of someone feeling that they have a purpose, that there is meaning in their life. And Tom talked about the importance of his relationship with his children, for example, giving him purpose. And also that sense of having hope. Now, it might not be that the situation is going to improve right at this moment, but having hope that it will improve into the future. And importantly, people need to feel like that they are genuinely being supported by other people. Remember that someone can be surrounded by others and still feel incredibly alone and isolated. So it is important that they feel genuinely supported by people. So what can we do then in terms of suicide prevention? I think it's really important that we think about this in a multi-layered sense. So we think about what can an individual do, what can family, friends and the community do, and then also what can professionals do. Of course, it's really important for all of us that we're always thinking about our health and well-being and that we're doing things like seeking assistance when we need it. And if we're needing to engage in professional support, making sure that we're seeking support which is evidence-based and following the treatment that we're being provided, knowing where to get assistance from. But I also think we need to be realistic. If someone is in crisis, is highly suicidal at that time, it is unreasonable to think that they're going to be able to think logically and solve all of these problems by themselves and follow this nice checklist of things that they should be doing. That's why the middle column is so important here, that we need friends, family, the community, supervisors, commanders, everyone to be taking some responsibility. Most important thing that you can do is to ask directly, are you thinking about suicide? Are you thinking about killing yourself? And then if the answer is yes, you need to know what to be able to do about it. So make sure you are informed. Know where you can link people in with support. Know that you can do that with confidence and that you can help them with getting assistance, actively help them to get assistance and actively follow up with them. And then in terms of professionals, I'm thinking here about mental health professionals and health professionals and anyone who's working with vulnerable populations, make sure that you're staying informed. There's lots of fantastic training courses out there. Make sure that you're attending those training courses and staying informed about the field. Most organisations and professional bodies have protocols or guidelines that you need to be following. Make sure you know that they are and that you follow those protocols. And also consult with others. Never do anything in isolation. Get supervision. Make sure you're consulting with others. And across the board, everyone should be making sure you're actively following up with people. This can be hard because sometimes people who are in crisis will be pushing back on support. They can be difficult people to be working with, so we all need to actively work to assist them and to always be remembering that our best chance of suicide prevention is to be working across that entire continuum of what we can do as individuals, what we can do as mates, as peers, as family members, as community members, and what we can be doing as mental health professionals. Thanks, Mark.
Thank you very much, Nicole. That's wonderful. That's a veritable goldmine of information in there. And, of course, people will have it available when we put the video out. They can have a look at those slides in more detail. But thank you for that. And that comment that you made just a minute ago about asking directly about suicide, I think is so important. It just happens to relate to a couple of questions that have come in, so we'll do that in just a minute. Before we do that, I just wanted to go back to the idea of conducting a risk assessment. And you kind of touched on this in your talk, really. But I guess some of the things that we know are risk factors are not necessarily helpful when you've got someone sitting in front of you. Would that be right?
Yeah, that's right. And in fact, although you can do a very comprehensive mental health risk assessment, it only really makes sense for that moment in time. And we know that there can be great changeability in someone's circumstances. So whilst you might do an assessment and it all makes sense about what their protective factors are, by the time they've gotten home, they might have received a negative text message or had a difficult phone call with someone. So that can change their risk at that time. So whenever you're doing a risk assessment, we also like to think about changeability. Is it likely to change, and what are the factors that could change that? And how confident are we in the risk assessment that we're able to make? Do we feel like we're getting good information from that individual, or should we be trying to get information from other people who know them as well?
Good point. OK, and we'll come back to some of that stuff. I think there's a lot of important stuff there. But we need to move on, and it's now time to come to your questions and comments. Again, thank you very much to all of those of you who've already sent in questions, and I've got some on my little iPad here in front of me, but do feel free to send in some more if you like. Our speakers, I think, have already answered some of the questions, but those that haven't been addressed, we will certainly try to get through as many as we can. For those that we don't manage to get through, my understanding is that VVCS is going to prepare a spreadsheet with all the questions on and brief answers to each. So if your question doesn't get answered today in the webinar, hopefully you'll be able to source that and have a look. I would like to start with something, though, that several people have sent in, several people are concerned about, and I can understand it entirely, and it goes back to this idea about what a sensitive and difficult issue this is. And we've got two related questions. We've got one from Bill, who is asking exactly the point that you were raising, Nicole. Is there a risk that asking someone about suicide might actually prompt them to do it? I think that's a commonly held fear. And then Judy, I think, speaks for a lot of people when she says that if she asks someone how they're going and the person says they want to kill themselves, she wouldn't know what to do, so she decides not to ask them. I reckon both of those are understandable concerns, Tom. Do you think they're justifiable, that talking about suicide might prompt it, or that you have to have some kind of magic answers?
No, not at all. I think you need to ask that direct question. By asking that direct question, you then open and give that other person opportunity to start discussing what's really going on, what's the underlying issues. So, there's still acceptance out there in the community that we're trying to get that acceptance. It's okay to ask the question.
Yeah.
Be direct. And because if they answer yes, as Nicole said, and I'll reiterate, you can then put in a plan or get them the right professional help.
Yeah.
But to ask that question, no doubt.
Absolutely. Even though it's frightening, I think it's important. Yeah. Did you want to add?
Yeah, I think that's a great point. It's a really hard question to ask someone. Even as a mental health professional, it's always a hard question to ask someone directly. And that's why it's important that you have some confidence in knowing what you would do if the answer is yes. What are the services that you connect them into, or who are the other people in your support network that you can reach out to help you to deal with this issue with this person. But it's also important in terms of talking about this openly to break down some of those stigmas and barriers to care. It's why it's so important that people like Tom are willing to come and share their stories so that we can destigmatise being open and having that conversation, because unless we're talking about it, we can't help each other.
I just like to add too, Mark, and put it out there for the community to understand too. If you don't feel confident enough to be able to ask that question, or you don't believe that you have the right resources, go and find a friend or someone that can go and ask that hard question. Don't put all the burden on yourself, but go and seek help to actually go and help that other person.
Very good point. And I'm not sure if you'd agree, Tom, but it strikes me also that the person who is feeling that they want to kill themselves, often for someone else to raise the issue is an enormous relief that they can actually talk about it because they're so frightened of mentioning that to someone else. So it can be a great relief for them, I guess.
Yeah, and you can put your head down on the pillow that night and say you've done everything in your power to be able to help that person.
Yeah. OK, I'd like to pick up on a point that you made briefly in your talk, and we've got a question here from Kerry, who's asking about the link between mental health diagnoses or psychiatric disorders and suicide, which you kind of alluded to. But also, Kerry is asking about really the role of situational factors or environmental stress, if you like, on people's feeling that maybe they can't cope and that life isn't worth living. So we don't have to have a mental health problem, is that right? We don't have to have a psychiatric diagnosis.
Yeah, absolutely. There's lots of reasons, of course, which can lead to people thinking about suicide or acting upon that. And in fact, some of the more recent research is starting to try to tease apart what are the differences between those people who think about suicide, so ideate, versus those people who then progress on to acting on those thoughts. And there is an idea that perhaps they're really quite separate groups and we need to understand those differently. But that whole idea that mental disorders do not necessarily lead to suicide is correct, but it can be one of the risk factors. Some research will say that it's up to 70 to even 90% of those people who attempt or complete suicide do it within the context of a mental disorder. So it is one of those factors that we need to be aware of and to be thinking about when we're supporting someone or doing a mental health assessment.
And but equally, of course, situational stress. And I think I'm right in saying that one of the highest groups is the elderly, who often I think are perhaps weighing up their lives, and situational stress is, they've decided times over. But very tricky issue. OK. Lawrence asks us, what supports are out there for veterans considering suicide in Western Victoria? Now, that's a pretty specific area, but I'm going to throw it to you, Tom. Have you got any advice for Lawrence about getting resources in Western Victoria?
This answer isn't just for Western Victoria, it's for the whole community out there. So any community you're in, there will be, first of all, if you can ring your GP, you can jump on the internet, there's plenty of information, resources. You can also contact your local mental health provider, or another option is to call the hotlines. You've got Lifeline, you've got your Beyond Blue, all those organisations.
Yeah. So talking to someone and mates, I suppose, are going to be, mates, friends, loved ones are going to be a key starting point for many people?
Yeah, because that person themselves might not be in a position to do the research. So, reaching out to a friend, they can jump on and do some research.
Yeah,
the options are limitless.
They don't. There aren't, unfortunately, positions like yours all over Australia yet, are there? So we couldn't guarantee there's one of those. But my understanding is that VVCS would be able to provide contract counsellors pretty close. Would that be?
They have the outreach counsellors. So we have a cohort of outreach counsellors that help our VVCS counsellors, and that's just purely to reach out, to get out into those regional areas the best we can.
Yeah, OK. So we've talked a lot about the fact that there are a whole range of factors perhaps coming together that might lead someone to believe that life isn't worth living. A lot of the blame tends to get sheeted back to their military service, rightly or wrongly. So this is classic for you, Nicole. From Philip. Philip asks whether the ADF has made any progress in the way it recognises and responds to suicide risk in serving members. Have we got anywhere within Defence, do you think, Nicole?
Yeah, I think that we continue to learn, or Defence continues to learn and to make inroads on that. I started as a military psychologist in the 1990s, and back then we were providing suicide awareness training. But in terms of the sophistication of what we're doing, that certainly has improved over time. And it's a multi-layered approach about, I think, not just looking at doing awareness, but how do we train people? How do we train commanders? How do we train mates to be looking after each other? How do we make sure junior leaders know what to do? So a lot more sophistication in how we're doing it. There's also been a lot of investment in research and in looking at what are the risk factors. Things like the Joint Defence and Department of Veterans Affairs Transition and Wellbeing Research program, which is trying to look at contemporary serving and ex-serving and what are the particular risk factors for them. So there's a real dedication, I think, in terms of trying to pull apart what is a very tricky problem and to look at things like, for example, deployment risk is a good one. We often think about it, it's just those people who've deployed that we'd be concerned about, whereas we know now we need to be concerned about, in particular, young males, people who have never deployed, people who are single, and in particular those people who are leaving military service before they want to, and that might be because of administrative problems or medical problems, and this can be very difficult for people because they join the military for a career and feeling that what it is that they wanted to do and they're not had the opportunity to do that can be extremely stressful for people. So I think there has been some really good inroads in terms of what the Department of Defence is doing.
That's good. But
can I jump in there, mate?
Yeah.
For me personally, unfortunately, an event did happen in the military for me, but it was the way I didn't acknowledge it and take responsibility for how I was feeling after that event, and my behaviours, the chosen behaviours, which led me to that point.
I did want to ask you, Tom, actually, because Nicole there kind of alluded to the process of transition and how difficult it can be for someone who's coming out before they want to. Did you take advantage of the various services that were offered by Defence to help you through that process?
No, I didn't, and I chose not to. When I got that medical discharge, I felt that I'd let down my team, so I didn't really want to have that face-to-face or be attached to Defence anymore. So I went totally the opposite way. So I didn't know it. I didn't even go to a transition seminar. It was part of my post-out procedure, but I chose not to. And that's another important factor I'd like to put out there. Use all the resources that the ADF provide. And
I think it's good advice. And you've got nothing to lose by going along, have you?
No, not when you're getting out. That's
and
sure.
Who knows, you might actually gain something from it.
Can I just add to that point too, in that one of the biggest changes I think we've seen over the last couple of years between what Defence and Department of Veterans Affairs is doing is focusing on that transition and not thinking about it finishing at the point where you walk out the front gate and you've discharged, but to think about how do you provide support and keep linking people into services for that first year or first couple of years out of transition. And there's a lot of work which has gone into trying to improve those services and make sure people know what is available for them and to link them into services, the right services, when they're ready for those services as well, and not just presuming that right at the end of the career when there's lots of stuff going on, that's when they're best going to engage in those services.
Yeah, that's a great point.
Okay. I'm just looking for a very quick response to this, but I don't want to think that we're avoiding it because we've had a question from Laura and you touched on the idea of commanders, and she's saying that ADF commanders often interfere with recovery by some of the decisions they make and the way that they behave and so on. Is it justifiable criticism, do you think?
I think that any supervisor, not just in the military, there is a risk that they may not handle things in the very best way that they could. My personal experience is that most military commanders take their duties very seriously and try to work very hard to be supporting people. However, people don't always get this right, and that's where I'd be encouraging that don't ever do this stuff in isolation. And there's very good protocols around things like doing individual welfare boards. So decisions and management plans aren't done in isolation, and that helps to stop individuals making decisions that might not be in the best interest of the individual who's experiencing suicidal thoughts.
OK, I'd like to move on to what is a very interesting area. Kay from Brisbane has sent in a question. She's asking about the role of technology in the area of suicide, and I'd like to kind of expand that to include social media. And I might turn to you first, Tom. Do you think that social media has a role to play in perhaps helping us to recognise and respond to suicidal thoughts? Or
yeah, I do, Mark. I think it's there's a couple of things that I believe either technology or social media is a big part, and that is I've personally used it from my lived experience. I've personally used it to check up on friends. So I jump on their Facebook page. I'll look for signs. If they were up late, what sort of post they were putting on, if that was negative, if you were talking about sort of saying goodbye to friends or. So I use that, and I've often rung up and I've seen it, and then I've often made the call then and reached out to that person if I've known them. If I don't know them, I'd put out just a general notification out there: is this person okay? Can someone check on them?
Yeah.
And from the other point of view, the internet's a great research tool for those who are unsure on how to help someone or wanting to learn more about suicide prevention. It's a great tool. Google it. So much information is on that net now. So
perhaps sometimes sorting the good from the not so good, but still, I quite agree. There's a whole lot there. Do you want to add anything on the social media side?
Yeah, I think that social media, we see that people now are willing to share incredibly personal things via social media, and they do share when they're in distress. And it's a great way of being able to monitor and see warning signs and also changes in circumstances. And in fact, if you have a look at each of the really big social media platforms such as Facebook, Instagram, Snapchat, they all have policies now about suicide prevention and management and what they can do. So there's a few options that people can follow. Generally, the advice is that if you know the person, reach out to them. If you think that they're in immediate danger, then get them, call 000, get them immediate support. But if you don't know the person, you can actually put in a notification through to the social media platform, and they will check up on that person. My only observation of that is that those protocols are a bit hard to find. If you've got kids, talk to them about watching out for warning signs and what to do if they're concerned about someone, because it's a bit hard intuitively to know what to do. And also I'd be encouraging people, if you're hosting Facebook websites, etc., have a think about your own protocols, what you would do, what you'd be encouraging your members to do if you are concerned about someone and how they're travelling at that point in time, and if there are active threats of suicide.
And I think, you've both actually mentioned this, but Nick specifically says, what might we do if we see that someone's talking about suicide or threatening suicide on social media? I think you've probably both answered it, but can we just be a bit more specific? You talk about reach out to them. That's great words, but what does it actually mean, do you think? You get on the phone, you say, I'm a bit worried about you, mate, or...
You become you get physically involved.
Yeah.
You either try all means to contact that person.
Yeah.
And as we've discussed so far, so you can get a chance to ask them that direct question. If you can't, go to the next best thing, their family member, or go to the messaging and ask that question. That's really all I can advise on that. It's very important.
Yeah.
And it's great advice, because what we sometimes see is a bystander effect. If you think there's lots of people watching this playing out on Facebook, and surely someone's going to do something. So if you are reaching out to that person, I'd also suggest that you just put a post which says, I'm about to give you a personal message, or I'm about to call you, so that others can also see that something is being done to help assist that individual. Because what we also don't want is for them to suddenly be overwhelmed by people calling them or contacting them.
Very nice idea, yeah. Good thought. Now, we don't have time to go into it, but I guess you said there's a wealth of stuff on the internet, and there are presumably a number of apps that are also good for mental health support kind of stuff. So,
yeah, lots of great resources that people can get on the internet, or apps which are available through places like VVCS.
Yeah.
And Beyond Blue have a good app, an actual plan app. You can actually put a plan down.
A safety plan like yours?
Yeah, safety plan, and keep it on your phone. So for those people that are going through that cycle of suicide ideations, and
Well, that's very interesting to know, and that's that's good for us all to know, isn't it? Because you don't want to wait until you've got to help someone out before you try and find this thing. If you're working, if you've got friends that you're a little bit worried about, look it up beforehand. That's very good. I'm the one who's watching the clock here, and it keeps moving very, very fast. So I want to take you through a few questions relatively quickly, if we could. Sue Ellen has asked us, saying that a lot of veterans will seek help through the public health system. What kind of treatment do suicidal people get if they turn up to the emergency department at a hospital? Nicole?
All right, so first of all, they should be triaged to look at how immediate the risk is. And then there should be an assessment which is done by a mental health team or a mental health professional, and that will look at things like going through risk factors, warning signs, protective factors, and trying to work out, does this person need to, for example, be put into an inpatient treatment facility, or could we send them home? How do we put in safety management plan for this individual? How do we engage the family and other support services for that person? And hopefully, if they're doing their job well, it should include making sure that there's a follow-up plan and a management plan over the next few hours, the next few days, and a follow-up referral for that individual.
I guess the if there is fairly important, isn't it? And I guess our public health services are very overstretched.
Yeah.
Sometimes it might not quite work as perfectly as that. Do you have any experience of people you know or yourself turning up to ED suicide? Is it something that's talked about much?
No, I actually haven't.
No.
I've been involved in more than just doing that AAA to do a welfare check.
Yeah.
So police will go there and do that.
Yeah, yeah.
If in doubt, AAA for me.
Yeah.
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 Absolutely. Well, I think that's a safe bet. Brett asks us, now he asks an unusual question. He says, how can we prevent something that we're told cannot be prevented? Let me ask you, Tom, is that a fair assessment? Is it true to say we can't prevent suicide?
No, I think we can. As a community, we can definitely do everything that's available to us to openly talk about it, to be able to help prevent it. Because preventative is so much better than getting to that stage where I got. I didn't reach out early enough. I just didn't put my hand up and reach out for help where I needed to, and that got me to that stage where I was thinking about it. So we can prevent it.
Absolutely. Well, okay, it's a very important point to make, and I guess it's true in mental health generally that there are all sorts of myths and misunderstandings around, aren't there? And if there is an idea out there that we can't prevent suicide, we're saying very strongly that's not the case.
Right.
We certainly can. Good. In the same way that people say we can't treat PTSD, we can. We can. Not always 100% successful, but we can treat it.
Can I also just add too, but it's not we're not responsible for someone taking their own life too, and I think that's important to get out there to the community too.
I think that's a very important point too. I was going to ask about that, so yep. Now you've raised it. I guess I was going to say that no matter how caring we are and how good we are, the fact is that sometimes some people are going to kill themselves, they're going to suicide. So, but you're saying very important to remember that it's their decision?
It is their decision. And I think we mentioned it before, as long as we've done everything that we thought we could do at that stage, like one, asking that question, two, getting him into a safe place or getting him help, I think I'd be able to lie in bed and feel confident that I've done everything right.
Well, can I take it just a little bit further and say that even if we haven't done it, it's still not your responsibility.
No.
If someone makes a decision to kill themselves, that is their responsibility. Would you kind of go along with that?
Yeah, absolutely. We can provide support, we can provide a guidance, but you can't force someone to accept that support. We can't read minds either. If someone has really made that decision, it can be difficult to change their mind. It can be difficult to intervene. And we see people in supervised inpatient psychiatric wards who will die by suicide. So it's important that whilst we know that suicide can be prevented, it doesn't mean that we'd be able to prevent every single one of those.
Yeah, very important. And presumably, if someone finds themselves in that situation where a colleague, a mate perhaps has killed themselves, that person also needs to look after themselves, don't they?
For sure. When someone does commit suicide or goes through with the act, it can have a ripple effect. And it's not just the people close to them. It could trigger other people. So it's very important to... Lost my train of thought.
Well, those people look after themselves as well.
Go get help, get debriefed. And when I say debrief, that's a bit clinical, I suppose, but go to your friend, just talk about it. Openly talk about it. Any concerns you raise, you might have to go to a professional and get a good check over, you know.
But get some support.
Yeah, get support.
I agree entirely. You agree with that?
That's right. And it doesn't matter who you are. If you've been a family member or a friend or a supervisor or a mental health professional, we all need support. I think that if that has occurred, it can be extremely distressing for us. And it's important sometimes that you're reaching out and getting some objective support and perhaps even some professional support from someone else. Sometimes just reaching out to those people who've been also involved in that very difficult situation, it can be hard to get objective support and advice about what's going on. So that's something that important that we should also be thinking about.
And to just build on that a little bit, I guess if you're finding yourself in a situation where you're the kind of person that everyone comes to with their problems and you know, and so on, it's still important to look after yourself and maybe set some boundaries or...
Yeah, absolutely. Being able to set some boundaries and making sure that if, in fact, this is a time that you don't feel like you're in the right headspace yourself or that you don't have the resources to be supporting someone else who is in crisis, that's okay as well. It's all right to be setting boundaries, but to be looking at who else you can draw into this. Who else can you be linking that person into? So that's important for us all to be able to be aware of our own boundaries and know when it's okay to be getting someone else to be actively providing support for that person.
So important, isn't it? And you don't have to feel guilty about that.
No, that's being responsible, looking after yourself. You can't look after other people if you're not looking after yourself.
Yeah, exactly. I quite agree.
Definitely.
But that sort of recurring theme about linking the person into other support networks is seems to be very important. Who can they talk to? Who can we link them in with? So,
and just to follow on from a point that Tom was making around that whole idea that sometimes we do see this contagion effect, where that if someone in a tight-knit group, for example, has died by suicide, it can increase the risk for others. So have a look at who else you should be supporting and who else might be at risk in the aftermath of not just a completed suicide, but also a suicide attempt, which can also be extremely stressful and traumatic for those people who are involved.
I'm afraid that time has just about run out. It just goes incredibly quickly, doesn't it? But anyway, before we wrap up, I would like to ask our two panel members if they have any very brief take-home messages, any points that they'd like to leave you with before we finish. So let's start with you, Tom. Any key take-home points?
Ask the question directly. Safety for yourself and the person, and seek professional help for both of you too in the event of a suicide situation.
Good advice. And that first one, which I think is perhaps contrary to what a lot of people might think. I daren't ask about it, but it's so important, isn't it? Yeah.
Yes, it is.
So important. Thanks, Tom. Nicole, any take-home messages?
Yeah, I'm going to repeat the same one. Ask correctly, but also know what to do if the answer is yes. So you don't want to be trying to scramble around and find out what the services are in the midst of a crisis. Go find out what they are at the moment, what's available in your region now. Have a look at the list of resources which are available on the screen as well to do with the webinar, so that you know what you can do and how you can support other people.
Thank you, Nicole. And that's a very opportune moment to have a look at this slide about the available resources. And, of course, there are many that both Tom and Nicole have alluded to through today. I would draw your attention to the third and fourth dot points there. I'm not sure if you can see the slide at the moment, but VVCS does offer a whole range of training to people, to lay people, as it were, in assisting with suicide, in understanding it better and so on. So Operation Life and Assist courses are both very, very valuable in developing some basic skills in helping your mates really through this kind of stuff. I always like the At Ease website. I think it's brilliant for veterans and serving members and families and professionals. There's loads of good stuff on that. And then, of course, there are the standard, if you like, support lines, including Lifeline and Suicide Callback and the ADF All Hours line and Beyond Blue and so on. There's a lot around. So, again, having these kinds of things at your fingertips so you know it's there, particularly, as you were saying, Tom, as part of a safety plan, making sure these numbers are there, but also if you think you might be helping someone who's struggling a bit, they're well worth having. Okay, and I think if you keep an eye on the VVCS website and the VVCS Facebook page, information about these kinds of courses is always coming up. And of course, we said at the beginning, say it again now, VVCS is always there to provide support for veterans and their families when they need it. So make sure you have that number handy and don't be afraid to use it. Take the plunge. If you've been putting it off for a while and you feel that you'd like to chat to someone, give that number a ring. Have a chat to them. I would like to remind you, if I could now, to complete the feedback survey, which will come up on your screens at the end of the webinar. It is really important in terms of making sure that we're meeting your needs and trying to make things better in the future. But finally, I would like to thank you all very much for participating in today's webinar. I've been really pleased by the level of engagement and the quality of questions that you've been sending in and so on. So thank you very much for your engagement. Thank you to VVCS for putting on the webinar, and of course a very warm thank you to my colleagues Tom and Nicole for joining us on the panel.
Thanks.
Thank you again for participating and enjoy the rest of your day. Goodbye.